I am Dr. Selvaraj, your surgical educator from Malaysia. Welcome back to my series of surgical teaching videocasts. These are meant mainly for undergraduate medical students doing the surgical clerkship rotation. I promise you will become confident in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. Today in this episode, I am going to discuss 10 more MCQs on one of the causes for obstructive jaundice, namely the cholangio carcinoma, and few of the questions are from periampullary carcinoma as well. So I don't think that I need to explain the importance of MCQ for today's medical students, because in all their exams, both qualifying as well as competitive medical entrance exams, they have to appear for the MCQ portion of the exam, especially in competitive medical entrance exams. It is exclusively only MCQs. So this series of MCQ videos will give you a systematic way of revising the whole spectrum of general surgery topic by topic. But before we are going to discuss those 10 MCQs, I request you to watch this video, but this video is not on cholangiocarcinoma. This is on obstructive jaundice in children. Please watch this video. It will be useful. And after watching that video, you come again to this video. Let us discuss the 10 MCQs on cholangiocarcinoma as well as periampullary carcinoma. So MCQ 1, 66-year-old man present with painless progressive jaundice, pale stool and pruritus. Imaging reveals a mass at the ampulla of Vetter. What is the most likely diagnosis? A. Gallbladder carcinoma. B. Ampullary carcinoma. C. Cholangiocarcinoma. And D. Pancreatitis. Of course, the correct answer is B. Ampullary carcinoma, because ampullary tumors, part of the periampullary group, cause early jaundice, often painless due to early biliary obstruction. The other options are incorrect, because the gallbladder carcinoma more commonly causes pain and very late jaundice. And ampullary carcinoma is the correct answer. Cholangiocarcinoma usually involves hilar or intrahepatic ducts. And pancreatitis causes pain, very severe pain, and enzyme elevation, and not progressive jaundice. So reference is Subiston 21st edition, chapter 52. Coming to MCQ number 2, a 58 years old male is diagnosed with cholangiocarcinoma at the hepatic hilum, that is called Klatskin tumor. What clinical feature is most likely? A. Palpable gallbladder. B. Intermittent jaundice. C. Progressive painless jaundice with pruritus. And D. Hematemesis. Of course, the correct answer is C. Progressive painless jaundice with pruritus. Because the hilar cholangiocarcinomas obstruct bile flow proximally, leading to persistent jaundice and pruritus. Palpable gallbladder is often non-palpable because it is the duct is obstructed proximal to the cystic duct joining the common hepatic duct. So because it is proximal, the obstruction is at the level of common hepatic duct and even proximal to that. That is why there is no gallbladder distension. Intermittent jaundice suggests gallstone in the CBD, that is choledocholithiasis. D. Hematemesis not typical of cholangio carcinoma. Hematemesis is always GI problem, not choledochal. I mean the ducts of biliary duct. It's not a problem of biliary duct. So reference is Schwartz surgery, 11th edition, chapter 38. Coming to MCQ 3, 63-year-old woman has jaundice, weight loss, and the CT reveals a mass involving the distal bile duct, sparing the pancreas. What is the appropriate surgical treatment? A. Total hepatectomy. B. Whipple's procedure. C. Hepaticojejunostomy. D. Segmental hepatectomy. So the correct answer is, of course, B. Whipple's procedure. Distal cholangiocarcinoma is managed surgically with a pancreaticoduodenectomy or the Whipple's operation. Total hepatectomy is only for extensive liver involvement. Whipple's procedure is the correct answer. Hepaticojejunostomy is a palliative or reconstructive procedure. Usually we do hepaticojejunostomy in a Kasai's procedure. This is called. And segmental hepatectomy for peripheral intrahepatic tumors, we are doing segmental hepatectomy. Reference is 28th edition Bayesian law. Coming to MCQ 4, 70-year-old man with ulcerative colitis present with jaundice and fatigue. Imaging shows multifocal strictures of the intrahepatic biliary ducts. What is the likely diagnosis? A. Primary sclerosing cholangitis. B. Gallstone obstruction. C. Hilar cholangiocarcinoma. D. Autoimmune hepatitis. Of course, the correct answer is C. Hilar cholangiocarcinoma. Explanation: patient with primary sclerosing cholangitis are at high risk of developing Klatskin tumors. That is hilar cholangiocarcinoma. Okay, that is the thing. And the A is primary sclerosing is a precursor but not a cancer by itself. This PSC or primary sclerosing cholangitis. B. Gallstone obstruction less likely in multiple strictures and with ulcerative colitis. Autoimmune hepatitis does not cause ductal strictures or jaundice. Reference is Davidson, 24th edition. Coming to MCQ number 5. Patient with suspected periampullary carcinoma undergoes endoscopy which shows ulceration at the ampulla. What investigation is best to confirm the diagnosis? A. Serum CA19-9. B. Breast cytology. C. Endoscopic biopsy. And D. CT scan. Of course, the correct answer is C. Endoscopic biopsy. Direct biopsy of the ampulla via the endoscopy provides definitive tissue diagnosis. And serums, this CA19-9, it is a tumor marker which is not a diagnostic test. The breast cytology is low sensitivity, so B is also incorrect. D is also incorrect, CT scan. It is good for staging, but not for histology or for diagnosis. Reference Sebastian Textbook of Surgery, Chapter 52. Coming to MCQ number 6, a 62-year-old patient has cholangiocarcinoma involving both right and left hepatic ducts. Which type of cholangiocarcinoma is this? A. Intrahepatic. B. Perihilar or Klatskin. C. Distal extrahepatic. D. Diffuse sclerosing cholangitis. So the correct answer is, of course, B. Perihilar or Klatskin tumor. Klatskin involves the bifurcation of the hepatic ducts at the hilum. So this is the typical Klatskin tumor. Intrahepatic usually confined to intrahepatic branches only. Perihilar is the correct answer. Distal extrahepatic, C. that involves the distal CBD. And diffuse sclerosing cholangitis is a benign inflammatory condition. Reference is Quartz 11th edition, chapter 38. Coming to MCQ number 7, a patient with unresectable cholangiocarcinoma present with pruritus and bilirubin of 18 milligram per deciliter, what is the most appropriate next step? A. Chemotherapy only. B. Liver transplant. C. Percutaneous biliary drainage. D. Observation. Of course, the correct answer is C. Percutaneous biliary drainage. It relieves biliary obstruction, improves symptoms, and allows chemotherapy. A. Chemotherapy only should follow decompression also. So it is not just chemotherapy alone. B. Liver transplant only for selected early stage, very early stage cases only. D is observation. It is inappropriate due to worsening jaundice. Reference 28th edition of Bailey and Love, biliary surgery chapter. Coming to MCQ number 8. Which of the following tumors is not induced under not included under periampullary carcinoma? A. Pancreatic head carcinoma. B. Ampullary carcinoma. C. Distal cholangiocarcinoma. And D. Gallbladder carcinoma. So the correct answer is D. Gallbladder carcinoma. Periampullary carcinomas arise within 2 cm of the ampulla, including head of the pancreas, distal CBD, ampulla, and duodenum. So gallbladder is far away from this region, so it is not periampullary, part of periampullary carcinoma. So the all other A, B, and C are wrong because pancreatic all fall under periampullary group A to C. D is gallbladder carcinoma. It arises from the gallbladder, not in the periampullary region. That is the only thing. Yeah, that is the correct answer. Reference substance 21st edition. Coming to MCQ 9, what is the most common histological type of cholangiocarcinoma? Squamous cell carcinoma A, B, transitional cell carcinoma, C, adenocarcinoma, D, small cell carcinoma. Of course, the correct answer is C, adenocarcinoma. Explanation: over 90% of cholangiocarcinomas are adenocarcinomas. The all other answers A, B, and D are rare in the biliary tree. Reference: Robbins' pathological basis of disease, 10th edition. Coming to MCQ number 10, which tumor marker is often elevated in cholangiocarcinoma? A. CEA, CA15-3, CA19-9, and D. alpha fetoprotein. Of course, the correct answer is C. CA19-9. CA19-9 is elevated in many patients with cholangiocarcinoma, but is not diagnostic. CEA elevated in colon and gastric cancers. CA53 is a tumor marker in breast cancer. D alpha fetoprotein, it is for hepatocellular carcinoma and non-seminomatous seminomas. Yeah, that is testicular tumor. Reference is 28th edition of Bailey and Law. These are the reference books. The first two books are problem-oriented books, excellent books, and all other books are having case-based discussion or case-based questions. So you have to work all these case-based questions in these books. And this is the link for what are the books available to become a competent general surgeon. This you can click and you can watch that also. So this is my own book. I created this book, a clinical case discussion. It contains more than 120 case scenarios divided into 9 modules. So you can download this book by clicking this link. You can download the whole book. It's around 400 plus pages. And if you want to watch my video, here you can click, you can see the playlist of videos. So there are 9 modules in this book, and I have included 9 videos. For each module, one video. You go and watch either my video or you can download the book and read. Very useful book. Please kindly go through this book. Thank you very much for watching this video. If you think that these videos are very useful, kindly share these videos in your social media. Thank you very much for watching this video. Until we are going to meet once again, bye bye.